Good evening. Welcome to the Citywide Healthcare Forum. Go ahead and find a seat. If you haven't submitted a question yet and you would still like to, find one of the friendly folks in the green lanyards like this and get one of the question cards from them, and they will be happy to collect it from you as well. My name is Jensina Hawkins, and I'm the moderator for this evening's forum. For anyone who knows me, it's kind of funny because I am not moderate in anything I do. I'm the Vice Chair of Churchill Area Neighbors, or CAN, one of Eugene's 23 formally recognized neighborhood associations. On behalf of CAN, I would like to thank the people and organizations who have made this event possible this evening. Willamette Christian Center, providing this venue and the coffee. City Councilor Randy Groves, who I cannot say enough about for the amount of support he has poured into keeping us all going as we put this together. County Commissioner Pat Farr, District 4. County Commissioner Lori Traeger, District 3. Mayor-elect Karin Knutson. Landscape Dynamics, locally owned and operated in Churchill Area Neighbors. Emergence, Healthcare for All Oregon, Eugene Healthcare Coalition. Active Bethel Community, another one of Eugene's formally recognized neighborhood associations. Jerry's Home Improvement, Churchill Estates Retirement Community, who provided the beverages out there on the table. John Quetzalcoatl-Murray of Whole Community News is operating the camera and the YouTube live stream for us tonight. We also want to recognize the elected and appointed officials, in addition to the panelists, who have made the time to be here and listen to our community. Okay. In the room, we have Mayor-elect Karin Knutson. We have staff from Congresswoman Val Hoyle's office. I believe we have staff from Senator Merkley's office. I haven't seen them yet. I was told Representative candidate Monique Despain is here. Obviously, City Councilor Randy Groves is here, also making the wheels on the bus go round. Demond Hawkins, president of the NAACP, is here. Some of you know him as Mr. Jensina. We have Lane County Commissioner Heather Buck here. Jameson Otten, the CEO of Lane Transit District, is here. And those are all that Randy wrote for me. So we'll go into our panelist introductions. These 8 very busy individuals have acknowledged the importance of this forum and carved out time in their work, campaign, and personal schedules to take your questions this evening. Your questions and as many of the panelists' responses as we can get will be posted on the Churchill Area Neighbors website at eugenecan.org. We do have a QR code for you if you want to take a picture of that. For the panelists, please give us your name, title, and a brief rundown of why you're here this evening. Please keep your introduction to 2 minutes. I know that's going to be hard for you, Dr. Jones, but it's okay. We still love you. And tell us why you're here, and try to keep it as short as you can so we can get straight into the Q&A part of the event this evening. Speaker Fahey, we'll start with you.
Great. Good evening, everyone. I'm Julie Fahey. I am the Speaker of the House in Oregon. I'm also the state representative for the House district that we are in right now. So I was elected in 2016, and representing West Eugene and the Bethel neighborhood, and I just live a few blocks away. So Churchill Area Neighbors is my neighborhood association, and then just in March I was elected to be the new Speaker of the House. So very excited to be serving in this role and to be here tonight, listening to all of the needs that our community has around healthcare. I really would love to hear about your thoughts, your concerns, and your struggles with accessing affordable healthcare in our community. In the legislature, I'm going to talk for my remaining minute, just a little bit about how we think about healthcare in the legislature. And I know Representative Nathanson has been doing some specific work on access to care in this community. But at the legislative level, from a statewide perspective, we focus on both access to care and affordability of health care. So from an access perspective, to me that means making sure that there are enough providers and clinics and hospitals in every community around the state in Oregon so that people can access the care that they need. From an affordability standpoint, obviously it's that people can actually afford to access the care that's there. And so we in Oregon have made great strides on affordability. We have one of the best Medicaid programs in the entire country, the Oregon Health Plan, for folks that are low income. And just this July, we created a new program called the Bridge Plan, which is for people who make too much money to be able to afford, to be able to qualify for Medicaid, but not enough money to actually be able to afford insurance on the exchange. So that's called the Bridge Plan. It just started operating this year. By all accounts, it's going well, expanding access to affordable care for middle-income Oregonians. Lots of work to do, but I'm at 2 minutes, and I'll pass it over to Representative Nathanson.
Thank you. I'm Nancy Nathanson, state representative representing North Eugene. Formerly, I was on the city council. I lived in and represented this exact neighborhood, Churchill. In just 2 minutes, I'll describe for you the work I've done as a local legislator working on both the hospital closure and the loss of doctors at OMG. I think that's why I got invited to be here. Last year, I worked with local stakeholders to develop realistic responses to the hospital closure and loss of an emergency department. I drafted and passed legislation in March that does 3 things. It speeds up hiring nurses already licensed in another state. It pays for an additional crew since ambulances will be traveling farther and longer to get to the remaining 2 hospitals. And over $3 million goes to an innovation fund to reshape urgent care in our area, to relieve pressure on emergency departments and to get care to people where they are, not just only how to get ambulances to people and take them to hospitals. As soon as I got home from the legislative session in Salem, I started looking into panicked social media posts from people who couldn't get an appointment with someone at Oregon Medical Group. I made calls like to the Lane County Medical Society, even the State Department of Justice. People were self-rationing prescriptions, reducing the dose or frequency to stretch medication as long as they could because they didn't know when they'd be able to get a refill. Medications for things like lupus, diabetes, and Parkinson's disease. Annual wellness checks for children were being canceled and they missed their routine and required immunizations. The wait time for appointments grew from 2 to 3 weeks to 2 to 3 months. Many clinics and doctors were not accepting Medicare patients. People were anxious, scared, angry. One pointed message said, quote, "My cat has better health care." Doctors, too, were under stress. Those who wanted to leave Oregon Medical Group wouldn't be able to continue seeing patients locally and feared action for violating something called a non-compete agreement in legacy contracts that Optum had inherited from Oregon Medical Group. So there was a noticeable and costly impact on the rest of the healthcare community as people without doctors leaned on calling 911 or showing up at the hospital emergency department for what otherwise should be primary care. After my colleagues and I sent a letter to Optum, Optum agreed fairly quickly to not enforce non-compete language, and they also committed to continue processing prescription refill requests. I am currently actively working on legislation that will be proposed for next year.
All right, I'm up next. Good evening, everyone. I'm Jim McGovern. I'm the Chief Hospital Executive for Peace Health in the Oregon Network, so I have responsibility for Riverbend, Cottage Grove, and Peace Harbor and Florence. I'm an internal medicine hospitalist by background. I've been in this community for about 5.5 years, so May of 2019. I also live in the neighborhood. Why am I here? We're one of the main suppliers or not used to big crowds. Anyways, we provide healthcare to a large portion of the community, and you're our customers. So being here to listen, to have conversation, to just kind of understand the experience is important to me, important to Peace Health, and I'm looking forward to the evening. Thank you.
Thanks, Jim. Good evening. My name is Phil Kapp. I serve Optum as the Executive Medical Director for the state of Oregon. My accountability is for all the care that is delivered in the state. I joined Optum to take on this role about 9 months ago. Have been here in the Eugene area helping to move OMG from where it is today to where it needs to go for a sustainable future. I also have accountabilities in Corvallis and in the Portland metro area where we also support care. I'm a family physician by training. I actually have an addiction psychiatry background before that, and my clinical practice area is really working with addiction and pregnancy, mostly with heroin and methamphetamine in the Seattle area. I came up at Providence St. Joseph's Health and worked for about 15 years in that ministry, working to bring affordable care, mostly to rural communities that are really struggling with it. You know, my role at Optum is to really, as I see it, make sure to chart a course to a sustainable healthcare delivery future. That change is very difficult, and for us it involves really reimagining and reinventing how we deliver care. From the advent of digital to partnering with our community partners around creating new access points like urgent cares and other access points, as well as really transforming how care is delivered in the clinics by the care teams to shift from a panel-based model to a population model. So all of that is difficult and takes time, but I didn't sign up for easy. So I'm really honored to be here with other healthcare leaders and to listen and then to learn about what the future needs to look like for this community. Thanks.
Is this on? Oh, great. Hello, I'm Jeannie Savage, and I use she and her pronouns, and I am the Chief Medical Officer at Trillium Community Health Plan. I'm also a family medicine physician and OB provider for Salud Medical Center in Woodburn. I've been there for about 20 years. Why am I here? Well, first of all, I came down to move my daughter into the dorms at University of Oregon. So I'm a duck, my dad was a duck, so we got the third gen going. Very excited about that. I also wanted to come here to be part of this, to hear what the community has to say, because we run a community organization, basically. Our Medicaid plan is to serve you and to serve your neighbors and to serve the city here. So we can only do that by listening, being humble, and trying to do better every day. I think the only thing that would be probably good for you to know is I have a practice that I still attend, and I left that practice because I was exhausted about 4 or 5 years ago. I work in a federally qualified health center, and I was seeing 20, 24 patients a day and trying to make a difference one-on-one every day, and I love it. I still see people now that I delivered that are now getting married and having babies, so I love that. I love the connection I have to my community in that area, and I absolutely want to continue to do that. What I also wanted to do was to try and make a difference, because like you, I was struggling in seeing my family get care, seeing my patients get care, and I wanted to make a difference on a bigger level. And the only way I felt that I could do that was to get inside of a system that I could not stand. So as a frustrated primary care physician, I said, well, maybe I should join insurance. I don't know how that really makes sense, but I felt that we need to be led by people who know what clinical work is like. And we need to have people making those decisions who have been in the field. So I'm very happy to be surrounded by people who have been working in the field. But I straddle that every day in the work that I do. I straddle the care I do as a PCP with the care I bring as an administrator in a Medicaid plan. So I want you to know that the people inside of these towers that we call are good people. There's people in there that have good intent, that want to do the right thing. We focus every day on equity, on getting rid of disparities, and on working to make this system better. It may seem like we're really far apart at times, but the reality is that we live together, we're all in similar communities, and a lot of us want the same thing. So I think when we start these conversations, it's really good to look around at each other, have empathy, begin with positive intent, understand that we want the same thing in a lot of ways, and we just have to work together to find a way to get there. So I'm here to listen and try to do that and learn more about these communities, and then hopefully me and Damon, my partner right there, we're gonna make a difference for you all working together and working together as a team up here.
Hi, good evening. My name is Eve Gray, she, her pronouns. I am the Director of Health and Human Services for Lane County. And I am here today because we care deeply and do a lot of work in healthcare within Health and Human Services in our county. From working at a community level in monitoring and responding to community health problems or emerging threats in public health, to providing direct service, which we do a lot of primarily in primary care and behavioral health. We are now approaching, in our primary care space, serving 10% of Lane County's population. And with the 2 new clinics that we are opening in the last, it'll be over a span of 2 months. We just had a grand opening for our West 11th clinic, thanks to Peace Health for their partnership and helping to get that facility in our hands and get that up and running to make sure we maintained access in West Eugene. And our South Lane clinic that we are opening at the end of the month. Well, beginning of next month will be the official patients in the door. We are expanding primary care as rapidly as we can. We've brought on at least 10 providers this year, although we sign more, it feels like, every couple of weeks. So we are working very rapidly to make sure that we are addressing the access needs for primary care in Lane County. On the behavioral health side, we are one of the largest behavioral health providers. We do a lot of work that is mandated with our partnership with the state, and we also do individual one-on-one care. We are the safety net for both primary care as a federally qualified health center and behavioral health, treating the individuals who have the most significant needs within our community. So I look forward to hearing more from you, talking with all of you about what you see as your needs in your community, and thinking collaboratively with you about how we can help address those needs.
Hello, my name is Dr. Nicholas Jones, and I think I'm here because I am a young, outspoken physician. I'm a family physician. I moved here back in 2019. My wife and I were seeking work-life balance in the beautiful Pacific Northwest. I only looked at positions that were independent, physician-owned practices. I understood in my residency training the inherent conflict of interest that there can be with working for hospital systems or private equity looking to, put profits over patients, or insurance companies. And so Oregon Medical Group in 2019 was fantastic. Instead of wining and dining me, they sack lunch and waterfalled me, which was amazing. And the group of people that I worked with there over the 3 years of the pandemic were fantastic. They're some of the most caring and hardworking, resilient people I've had the pleasure of working with. However, over the 3 years that I spent there, that physician leadership that I was seeking increasingly became apparent that it was more physician middle management than anything else once they had been acquired by Optum. There wasn't really, we didn't feel empowered, or I didn't feel empowered to put in changes that directly impacted patient care. And decided that if I thought care could be delivered better, I better prove it. So in 2023, I founded Clear Health Direct Primary Care, where I'm able to focus on advocacy, affordability, availability, and accessibility for patients. Some of that advocacy work that I do, I serve on the board for the County Medical Society, trying to strengthen connections between physicians in our community. I serve on a corporate practice of medicine work group and a universal healthcare access work group through the Oregon Medical Association. And additionally, I'm a part of the External Affairs Committee for the Oregon Academy of Family Physicians, because it's, as a young, outspoken physician, I think it's not enough for my practice to do well. I think we need to rethink healthcare. We need to rethink the incentives and the core underpinnings of how healthcare works. Because unfortunately, it's my perspective that right now, the healthcare system is unfortunately working as designed, and we just struggle to access care. And as physicians, as nurse practitioners, as physician assistants, we do our best day by day, patient by patient, to make connections. That's why a lot of us go into the field. But there's just a lot of people out there that we can't help. And unfortunately, the way incentives and the system is designed, it encourages volume. It encourages the number of visits per day or clicking a ton of boxes to prove that you as a physician have value, but also to make patients look as sick as possible on paper so you can get higher rates of reimbursement. Yeah, that's me talking way too long. Thank everybody. I just wanted to thank everybody for being here, and I will pass on the microphone.
Good evening. I'm Delisa Mishin-Tubby. I'm the Executive Director at Volunteers in Medicine Clinic. I feel healthcare is a right. We're a free primary care clinic for the low-income, uninsured, underserved adult population. And VIM is here to collaborate with our partners here on the stage because we really want to be that true safety net clinic. And one thing about Volunteers in Medicine is, like I said, we're a free clinic. We're able to pivot into what the community needs us to be. And that's not to say their patients, his patients, my patients, is to say this is our community that we're taking care of. And Volunteers in Medicine wants to be whatever the community needs us to be to take care of the patients and the community. And I'll tell you now, a healthy community is a thriving community. And so that's where we're at. And I also live in the Churchill district, and I'm also the pastor of St. Mark's CME Church, which is in this district as well. So we're here to hear you, we're here to listen to you, and most of all, we're here to understand. Thank you.
All right, I am supposed to issue a reminder to silence your phones or put them on vibrate if you can, please. Let's do a little exercise to get the evening going. In the last year, if you have lost your PCP, had to wait to find a PCP, or had to wait just to see your own PCP, raise your right hand. In the last year, if you needed emergency medical attention and had to go to Springfield to get it, raise your left hand. If you or anyone you know has experienced either or both of these, or if you're worried about the shortage of health care in our community, put both hands in the air and wave them like you just don't care. We received well over 60 questions in advance of tonight's event. The panelists have seen some of the questions. They don't know which ones we're going to throw at them this evening, and they don't know who we're throwing them at. We are going to start with a softball one, and we're going to start with Eve Gray, and don't get used to it being this gentle, Eve. This one is from Sarah Zoll, who is the chair of Churchill Area Neighbors. Is there an influx of patients that is adding to the wait times for PCPs, or is it just a shortage of providers? And if there's an influx of patients, where are they coming from?
Thank you. You know, I don't think that there are patients coming from outside of our community needing to access care who haven't in the past. Our population is growing, but not overnight to the point that it would create this type of shortage. What we are seeing, and in my opinion, is a shortage of providers. And we've seen this coming, we've seen it coming for my whole healthcare career, watching the population of baby boomers age and smaller generations coming behind, and knowing that the healthcare needs of our community are rising at a time that our workforce is not rising to meet that need and that demand. So we've seen this for a long time, anticipated it coming. COVID accelerated the pace of the workforce loss and transition because so many people left the field during COVID-19. And now we are in this very acute shortage right now, for which there are a number of reasons and a number of possible solutions. But there is no doubt that we have a shortage of providers, particularly in primary care and behavioral health.
I didn't time that well. All right, our second question is for Ms. DeLisa. This is from Healthcare for All Oregon, Lane County chapter. A quote from the Commonwealth Fund: "The U.S. spends twice as much per capita than other rich countries, lives shortest lives, and has the most avoidable deaths." What is your response?
We have to do better.
Yeah.
We must do better. That's truly my response to that, because we're here and we're better together. All of us working together to take care of our communities and our older people. We want them to live to be older. And I could say that because I'm an older person now and I want to live longer. But what I say now is that we have to take care of each other. It has to be from the baby on up. And it's not a given time that we die, but it's a time that we thrive until we go from this earth. So I would say we must do better.
Thank you. Question number 3. This one is for Drs. McGovern and Cap for Peace Health and Optum. I have heard and read that Lane County doctors and group practices have as many as 2,800 patients under their care. What are you doing to decrease the number to a manageable size to ensure more time with each patient and to decrease waiting times for an appointment?
I'm trying to hot potato this over to you, man. Yeah, I appreciate that question. Yeah, I just want to, as I answer that question, I want to reflect and agree with what you were saying, that, you know, the serial insults of, you know, attrition that was over 11% out of the Eugene community for over a decade. That's prior to COVID. And, you know, having a workforce that is really propped up by net imports, right? The Lane County has been a net importer of medical talent for as long as I can find the census data. And then add to that the insult of COVID, and then add to that the business disruption in the case of Oregon Medical Group of going through a combination with Optum Health, and you've got the perfect storm that has really taxed a really brittle workforce. So I really appreciate how you lay that out. You know, in terms of the acute shortage and what it means for panel sizes, the answer that I'm going to give is a little bit complicated and a little bit convoluted, so hang in there with me. You know, when I came up as a PCP, and I see some of my colleagues in the audience who know exactly what I'm talking about, we built panels. We had panels of anywhere from 1,000 to 2,000 to 3,000 patients who were our patients. And that that model has persisted for as long, certainly as I've been practicing. And it's a model that will continue in the future because we all need a medical home. We need a care team that knows who we are, knows our families, knows what our values are, and so on. In the context of a shortage, though, we have to reimagine and re-engineer how we're delivering care. This is the really hard thing. We have to bring more hands to the work, and you're scratching your head saying, well, where's the labor coming from? Because, everyone's read about the labor shortages in healthcare, so we have to fix that through a combination of really raising wages and making those types of investments in our workforce and our community. We have to work differently. That the advent of digital and these supercomputers that we're carrying around are really excellent ways to access a certain type of care, and none of that's enough. We have to build new access points that don't exist today. You've invested in some of the best urgent cares that I've ever seen up and down I-5. I know Dr. Ludke and his team at County have also been advancing that work, and it's not enough. So we have to create new access points, and we'll be launching our new urgent care to try to help with some of the access pressures in the first part of the year. But that doesn't solve the fact that there's still not enough providers for people that need to be a part of a primary care panel. And here is the difficult news. That is not getting any better. In 2030, we will be 35,000 primary care physicians short in this country. We are not training enough. We are not sending enough folks to medical school. We're not training enough people out of residency to get through that shortage. I'm not dodging the blame or the responsibility for making sure that we have a sustainable delivery system that delivers the care that's required to the community. But that's the reality that we're up against. So the advent of digital tools, the retooling of how we think about delivering care in the clinics, the creation of new access points, those are all core strategies. And then finally, bringing more hands to the work, and that's our evolution towards team-based care in the clinics, and I can talk to you more offline or in person if you want to know more about that. That work is hard. It requires millions and millions of dollars of investment every single year. And those investments take years to bear fruit. And that's the work. And that's what Optum's here to do.
So I'm usually fairly brief, so I'll add to that. From a Peace Health perspective, and I'm more hospital than outpatient, but we have hired a number of nurse practitioners to help manage the in-basket or the inbox of the physicians. So that allows us to add a little bit more capacity to them. We are hiring new primary care physicians. That's a short-term fix. We've opened up the Pleasant Hill Clinic as well, and we've moved out of the West 11 Clinic prematurely to open the Hilliard Urgent Care, knowing that the county was coming in behind us. But I'll just echo what Phil said. We cannot continue to deliver primary care the way we have traditionally. We just don't have the physicians, and so we have to find a different delivery model that creates more access, that delivers the same quality of care, that has the physicians in the places where they've been trained to be, and has other caregivers where they are adequate, have the knowledge, and can provide the care that they can provide. So just the way that the population is growing, the dearth of new physicians coming out, personally, I don't see the traditional model of primary care being sustainable into the future. Sure.
Do I have a second to add to that?
Sure.
Yeah. Thanks for mentioning just doubling down on the how we deliver care. I think, we live now and increasingly in a decentralized world. I mean, we're ordering things and they're coming magically, appearing at my doorstep. I mean, we've all been experiencing that trend as citizens and as consumers, and that trend has not yet come to healthcare, but that decentralization is coming. The future of healthcare is not based around a provider in a clinic. It's based around a patient and their family and their home. Just think about that for a minute. You have had a healthcare experience, as I have had, of being in orbit around a healthcare provider and their team, when the future is putting the care system in orbit around you. And that is going to take a minute. And I appreciate, we're not asking for grace, but I think asking for patience as we build toward that new future.
Please.
Or was it on now? Okay, sorry. I think that that's great, right? We need creativity on how we see people. So let me give you an example, because I think we often talk in these levels, and without a real example, I get lost. I'm very visual. So picture you walk into the clinic, you're a woman at 28 weeks pregnant, and instead of walking in and having just a visit quickly with your doc, you actually meet with a group of 5 or 10 other pregnant people, and you might be in a similar time period. I mean, for those of you who know, you have to drop your urine somewhere, so that gets tested. You got to get your blood pressure done and all of those things. But then you sit together and you talk a little bit about, okay, wait, we're all in the same time period of our pregnancy. What's happening with you? You get to talk about what is expected, what you're feeling, what's happening. But it's not just you. That's a care team, right? You might actually go in, get a physician, you might get the pharmacist, you might get the dietitian, and a community health worker who all comes in and works with maybe 5, 10 of you, right? So it's more of a group visit. It's a time where you can be around other people experiencing the same thing. So that is a creative way of seeing people more effectively. If we're going to do that, which I think we have a lot of creative minds that want to do that, then we have to make sure that the payment system is set up to support that. So if we have great ideas from everybody here and they're all in isolation, they're little bubbles and they're going to pop. So what we do is then say, okay, that's a great idea. Let's have these ideas of a care visit and say, okay, with our partners at OHA, with our partners and the legislators, how do we put that into a significant payment structure so that the people walking in are cared for, don't have a copay, and they know they're going to get their care, and the people who are providing it are cared for appropriately, and the people in the insurance company know how to pay them. So and then we get to, is that still lowering the panel size? Because that was the original question. And I don't know. We may still have a panel size that does that, but what about the expectation of you and of the people when we walk in? I may not see an MD. I might see a nurse practitioner. I might see a PA. And that might be okay. My mom, 85, she thought the idea of seeing a nurse practitioner, she was going to lose it. It's like, Mom, they know well. And I'm sorry, but there's 5 MDs and there's 10 nurse practitioners. Do you want to be seen or not? And she loves her nurse practitioner, loves her now. But her expectation had to be changed. So when we come up with ideas, these ideas need to come to everybody out here, and you all need to say, could I change my expectation to go with that? Can OHA and the insurance people, or Healthcare for All, whoever wants to do it, say, yes, we can support it, and put that all together? So let's think about globally, how do we lower that panel size by bringing the 6 pieces, including your opinion and your expectation of what it's going to look like, to the table?
Dr. Jones?
Yeah, I love all these ideas. I think they're great. And as that outspoken physician, I want to mention exactly and highlight one of those points is that we need to invest in it. Right, we need to have the underlying financials to support all of the care team, right? And you need to be able to have the resources and think, how do we put value, money, behind health rather than sickness? How do we get community health workers paid for? How do we get nutritionists, dietitians, physical therapists, all of these other care teams paid for? And the current model, the way things have been structured, is pay per visit. And that doesn't make sense. That's just sheer volume. And this new proposal or relatively new proposal or movement towards value-based care, the idea behind it is great. How do we pay for the value that these clinics can deliver? But we need to think beyond that. We need to think better than that. And my hope is that if we can have it so that family physicians, rather than medical students and pre-medical students rotating and just seeing the gobs of red tape and the binding of their hands and not being able to care for people, not being able to understand their patients and choosing, maybe I'd rather be in the operating room. Maybe I'd rather be a specialist, or as I like to call them, individualists. they choose primary care, and they can have a well-paying job, and they can have autonomy, and they can lead these teams and make a difference in their communities, and we can have an influx of primary care physicians. And I hope with some of the legislative actions that we take this upcoming session, and with some of the work Healthcare for All Oregon is doing, that we can help make that at a national level and let physicians, young physicians, know that this is an awesome state to work in. But yeah, that's my thoughts.
So speaking of legislators, Representative Nathanson.
Thank you. Dr. Jones just said something that I was going to raise, which is I've had the privilege of talking with at least 10 doctors in the last few months, doctors who are recently retired, doctors who are thinking of retiring, doctors who are still working. One of the benefits of being able to talk to so many physicians and people in the stakeholder group, and also visiting with Lane County Medical Society, is that I'm getting a lot of different points of view and perspectives. So I'm not a practitioner. You've just heard from the practitioners. I'm a legislator trying to figure out what is our role in trying to improve health care for our community. I do believe it is possible to make Oregon a state that is more attractive than other states. When people graduate, when they've completed their residency and their rotations, what makes Oregon the place where they want to be? Now, we know that if we could increase the number of residencies here in Oregon, it's very likely we could increase the number of doctors who stay in Oregon. But still, there are doctors who are looking for, where do I want to locate? We can make Oregon a more attractive place by changing the nature of the business models, the work environments, and the way the community receives them. And I believe it's possible.
Our fourth question came into the CAN Healthcare Forum email inbox about 20 different times, 20 different ways. So I'm going to give credit to the first one who submitted it, and I'm going to have a special guest that I was been informed is here in the audience come up and answer it. So this question is from Mary Adams, and the question is there a way to bring a hospital or at least an emergency room to Eugene? Thank you very much. Thank you very much. I made that up myself. So here to speak to that one, we have David Butler, CEO of McKenzie Willamette, and I have been chided very thoroughly for not inviting you to join our panel. My apologies.
Thank you. Yeah, that's an interesting question. And, you know, we've got a lot of colleagues up here. We work very closely with Dr. McGovern, Dr. Kapp. And we too see the shortage. It's very difficult sometimes to recruit physicians and specialists in this market. Just to give you an example, we've been trying to recruit GI doctors for the last 5 years. We've probably gone through 60 candidates and have 0. I hope Dr. Governor's a little better success rate than we have. But, you know, I understand all the economic issues that people are dealing with, that health systems are dealing with, physicians are dealing with. When we heard about University District closing downtown, you know, I understand all the economic reasons. We did some feasibility studies, and our team got together, and I've been at other organizations where we actually had satellite or freestanding EDs. So we've actually been talking with the Eugene city mayor and city managers. We actually met with the governor of Oregon and got kind of the green light to at least move forward with a CON, which is a certificate of need application. We've done a lot of due diligence in the Eugene area, and we found a local investor and a local developer that's willing to help us put this plan together. We're actually in the phase of getting a contract where we would sign the contract, and the developer and architects would actually put together a build and design phase for this. We combed all over, you know, west and south Eugene. There's not a whole lot of available sites, but we think we did find a pretty good site. Don't want to tell you about it because you might go out and buy it. But it's got great access. Over 25,000 cars go by there every day. And so we're very close to getting a contract agreement done and signed that we would go into the design and architectural design phase. At first, this was kind of a, it wasn't public knowledge. It is public knowledge now, so we wanted to share that with you, and we're willing to work with any of you. And initially, we're looking at about a 12-bed satellite ED. It would have the ability to grow and expand based on the site that we're looking at. So we feel that, we have two really good hospitals in this community. Unfortunately, they're both in Springfield. And even though it doesn't take you an hour to get across town, it's a disadvantage to have to drive all the way over to, McKenzie or Riverbend to get health care. We know there's a lot of great urgent care centers, and we appreciate that, but this would be a 24-hour, 7-day-a-week freestanding, or what we call a satellite ED. It would be on the same license as the hospital. Once we get the design and build phase done, we're probably looking about a 2-year or 2.5-year construction time frame. We do have a couple of our ED doctors, Dr. Wright and Dr. Hoyt. Dr. Hoyt is actually chief of staff. They run a great emergency room there. We know we work very closely with Jim, and we know there's a lot of wait times, and we're doing our best to try to accommodate that. We've worked very closely with Dr. Cap, and we see the shortage. We don't employ any primary care docs, but we do partner with a lot of groups, a lot of independent groups. So if we can't own them, then what we've done is helped with income guarantees, recruitment, placement, relocation, and those type of things. So we're trying to do our part, but we all have to work together as a team on this.
Well, there you have it. We can all go home now. No such luck. This question is for Dr. Savage. ORS 743B.602 allows health insurance companies to require doctors to use a less costly and less effective treatment in order to be covered before using a more effective, higher cost treatment. This may save money for the insurance company, but adds cost, ineffective treatment, or in some cases, negative results for the patient. What are your comments? And that question is from Lou Siniger with the Eugene Healthcare Coalition.
Yeah, this is exactly why I jumped into the hot seat, right? This is the hard part of it as a primary care physician, seeing folks. My job is to take the best care of people that I can. So I try to pick the best medication, and if that's what they need. Sometimes I actually don't prescribe anything, I just listen, which is often much more effective. But if in the case of the situation where I need to prescribe a medication of some kind, then I try to choose the best medication and the most effective, as well as the most cost effective. As a physician working in my clinic, not as an administrator, right? So I've got my physician in my clinic hat. That's what I do. Because my patients who don't have insurance, and many of them are non-documented, have to pay cash for everything they get. So we have a lot of conversation about what is going to be best for you. What can we do that's going to be the most effective, and the most effective in terms of efficacy in your health, and effective in terms of medication, and cost effective? Because I don't want to, frankly, they won't buy the medication if it's too expensive, because they have to pay rent and buy food for family. So that it's not really, I'm glad it's in law that we need to do that, because that's important. So what we don't want to do is keep a very effective medication away from people who need it. So I don't think we do that in any way with what Medicaid has done. Medicaid, and we follow the rules of Medicaid, have said if you have two treatments that are equally efficacious, and that means that they both will get to the response in your body, right? They will make a difference. We know that from studies, each one of those medications will help you with your strep throat, well, that's a bad example because everybody gets penicillin, but it will help you with your illness and get you to a point of healing. We know that those studies are equally efficacious. And I've got one that's 50 cents and I've got one that's $500 because it's not out of its patent. I'm gonna choose 50 cents because I have a certain pond of money, right? A certain mound of money that I get to spend in the Medicaid program. And if I don't choose to spend that cost effectively, then I'm not gonna get to treat very many people. So what I do is I say, well, how can I do that? How can I do that the best every day? And sometimes that means that a few people are gonna have to take a medication probably 3 or 4 times a day, when there is an equal medication that may cost more, but you only take it once a day. So then I'm like, well, if you're like me, I don't even take vitamins, I'll be honest. I mean, it's hard for me to take anything. So once a day is really, really good, right? If you only have to take it once a day and you get better, and this medication, you're gonna get better, but you gotta take it 4 times a day, brutal, right? But this one's 50 cents and this one's $500. So that's where I have to balance, what do I do? In some cases, you've gotta pay for the more expensive medication because you need somebody to get well right away and you need it to happen. And in other situations, you could say, okay, I need you to take this. I know it's a pain, but it's the cheapest thing we got, you need to do it. And people will do it if that's what they need to do. So there's no magic to this, and there's no nefarious behind, let me keep you from getting the drug. I'm trying to balance the cost of these very expensive drugs that are coming at us from all these different markets that might be awesome, you guys, they might be really good, and yet they might not be all the way trialed through all their trials. They may still be in a trial phase. Or they might be really, really good and super expensive and have an alternative that's really, really good, but you have to take it more times and it's less expensive. So we're doing the best we can. As these new medications come out, we do pay for those, and you'll see that. We have to pay. I have some medications that we pay, $30,000, $50,000, not just a year, but every quarter. And you need to, because cancer needs to be fought, because CF needs to be treated. But in general, with the most we can, we try to do equally efficacious, so equally effective and more cost effective, right? That's the best I can explain it. But it's not trying to keep care from anybody. I want people to get their care. I just have to balance the rules around the pharmaceuticals and companies and all of that. Did I answer the question? I'm not a politician. Did I? No offense. Did I answer the question? I think I did.
Dr. Jones, you can speak, but be quick.
I'll try and be quick on this one if my microphone turns on. There we go. So I totally agree, and this is something that opened my eyes in starting my own practice. But I can also see where it gets abused by payers. Right, I just today had a payer deny a vertigo medication on a patient and wanted an authorization and diagnostic codes and all of this stuff for something I can get for 3 cents a pill. Right, I have a patient whose oncologist needs her to get, or recommends, rather than mammogram after her mastectomy, MRI annually for surveillance because of the type of cancer, but insurance thinks that mammogram is equally efficacious, and so she has to pay out of pocket for that MRI, and agreed with the oncologist to do it every other year, not meeting the advice of the oncologist, but doing it for cost effectiveness. Well, her out-of-pocket cost for the MRI was close to $3,000. Per MRI that I was able to negotiate for $600, right? And the imaging facility is able to still make money at that rate, but that's what happens when you eliminate all of the different third parties and streamline the cost to what it really costs. And so I think that as a family physician, we take a lot of pride in trying to get the best treatment option for our patients. And a lot of times, especially in our training, we memorize the $4 formulary. We memorize what medications they can get, $10 for a 3-month supply. But we don't when we work in a practice and you've got dozens of different insurance plans, each with different types of tiers and copays and deductibles, we don't know what some of these things we recommend for our patients really cost. And that can be really detrimental. I can think of so many times where I send a patient for some type of study, some type of medication, and when we follow up, sorry doc, I never got it done, right? It was too expensive or it wasn't covered. And so I can understand where they're coming from, but at times it feels as a physician that it's the insurer or the payer practicing medicine and trying to pose as a medical provider rather than a payer. That's just my 2 cents and took way more than a minute.
Ms. DeLisa, did you have your hand up?
I did, but
I always do what Mr. Nathanson
he
wants,
did
always.
He said it.
All right, Reverend Nathanson.
Thank you. Seems pretty random, doesn't it? When something has a price tag of $3,000, you can negotiate it down to $600 and there's still a profit. Doesn't that seem like there's something odd about the network of healthcare in America? I have deep concerns about vertical integration and so many layers of third parties and fourth parties and fifth parties getting in between the different layers of healthcare. Whether we're talking about the corporate practice of medicine or pharmacy benefit managers or pharmaceuticals, something needs to change. The U.S. Congress has not had the nerve to tackle these issues. In some cases, we cannot do it alone as a state. There are little pieces of this, separate, discrete pieces that we can try to address as a state, but I am very concerned that the U.S. Congress has still not taken action to tackle the vertical integration and the additional costs. Let me give you one little factoid here that I was just looking up. Prices for brand drugs in the U.S. are more than 3 times higher than the average in other countries. A month's supply of Humira for rheumatoid arthritis in Switzerland is $822, in the UK, $1,300, in the U.S., $2,700. One vial of cancer drug Avastin, $470 in the UK, $1,752 in Switzerland, and more than $3,900 here in the U.S.
We're being robbed.
Okay. Let's try this again. The next question, Speaker Fahey. This is from Kathy Ward. Do we have a healthcare commission, like we have a utilities commission, that oversees what happens on a statewide basis and approves or denies takeovers of our healthcare systems and quality management of healthcare systems by these vendors?
That is a great question. Thank you for that. So we have an entity that looks at insurance rates, which was not the question. And we also have an entity that reviews the mergers of hospital systems. So it was actually just announced today, OHSU and Legacy up north in Portland, the Oregon Health Authority is going to review that proposed, I don't think it's a merger, but combination of those two entities. So we passed that bill a few years ago in the legislature, and it's really intended to make sure that when hospital systems merge, that there's not a reduction in access to care or quality of care, or in, in services like abortion, because there are some hospital systems that are run by Catholic entities. So we have some levels of review to do exactly what the questioner asked, but I don't think we have exactly, what was the very first part of that question?
Do we have a healthcare commission, like we have a utilities commission, that oversees what happens on a statewide basis?
It was quality of care too.
Healthcare systems by these vendors.
Yeah. So the other aspect of that question is specifically about the Medicaid program. We do have performance measures that folks like our CCOs, like Trillium, have to meet that OHA and others manage those contracts with the CCOs. I guess the global answer to that question is we have a somewhat fragmented oversight system, but there are pieces that really try to keep the consumer and the patient perspective in mind. I hope I answered that question. I'm not a healthcare executive, I'm just a politician, but.
Dr. Kapp?
Yeah, it's childproof. Oh, there it is. The one thing that I would just add to what that excellent summary there is that, the scrutiny is warranted because what we've experienced here over the last 50 to 70 years of physician really directed healthcare is bankruptcy of the middle class because of the cost of healthcare. If you think about the investments that let's just say employers have to make to keep up with the cost of healthcare, for about the last 40 years, the biggest driver there has been trying to keep up with the cost of delivering care. And when we get a lot of consolidation in market, the dynamics are that the prices go up and affordability then suffers. And so you were so eloquently talking to this balance around, how do you get at equity and affordability? And that's a really difficult decision to make when you're trying to deliver the best quality care, as Nick was pointing out. I need to do what's right for the patient. And so underlying here, the point I'm trying to make is that that affordability has got to be on our minds, and it's got to be, fortunately or unfortunately, one of the ways that we think about how we design the healthcare system of the future. I appreciated that comment about, the rampant drug prices. It's clearly an issue that needs a legislative fix because, our ability to control those supply costs as a delivery system, as payers, are non-existent in this country. So what we can control is how we deliver care in the most affordable and effective way. Back to what I said before, that's going to require us rethinking about how we access care. I'm really excited to hear about the new freestanding emergency department. We need more access and portals like that. And we need, in addition to having more facility access, we need more access to services that stop a little bit short of hospital level services because of the cost there. So that's an investment that Optum is making in this community. In January, we'll turn on our own version of a freestanding urgent care facility that's just sort of an emergency department. We won't be able to do penetrating trauma, gunshot wounds, acute stroke, or heart attack, but pretty much anything short of that we'll be able to manage, and which just adds, I think, to the service array that's building in the community and helps us deliver on that affordability aspect.
Dr. Kapp, hang on to that microphone. This question is for both you and Dr. Jones. I would like Dr. Jones to answer first, and then you can do damage control afterwards. This question is from Eugene Healthcare Coalition. What caused the exodus of physicians from OMG, creating an acute shortage of physicians in our region?
Yeah, okay, so that's definitely a big question. So, and I don't know that I can speak to everybody, but it's multifactorial, absolutely. I think a lot of us recognize that we probably had a physician for 25, 30 years, and they were going up in age, right? There's a lot of doctors that it's their identity, it's their calling, and they don't know how to let go of medicine, right? But a once-in-a-lifetime pandemic that risks killing you or your family is one good way of kicking, those docs to the curb into retirement that always seemed 1 year away. But I think another question we have to think about at a systemic level is, why is it so hard to run a clinic? Why is the overhead so high? And as it was mentioned earlier, why does it take millions and millions of dollars to play the game? That just doesn't make sense. And before the pandemic, payers didn't compensate for telehealth. You couldn't do a video visit with your doctor. You couldn't do a phone call visit with your doctor. And so Oregon Medical Group, being an independent physician-owned practice, is no stranger to sacrifice. So they allowed doctors to retire early. They voluntarily furloughed staff. They tried to consolidate locations, but they burned through a lot of savings, and I think that made them very vulnerable to working with Optum, and Optum, especially in the early days of the pandemic, was really helpful, especially with providing protective equipment, resources, support, helping Oregon Medical Group find a transition to this value-based care system. But again, like I alluded to in my slightly longer than 2-minute introduction, the physician leadership that we really cared about and that I felt was really important to how you run a clinic, that significantly changed over time. And it was subtle and it was slow, but more and more physicians got fed up, whether it was that they weren't allowed to change their hours around daycare and they had to make difficult decisions like that, or like was more common, suddenly we saw medical assistants leaving to Dairy Queen or to other jobs because we just weren't paying high enough. And it felt like every single meeting there would be physicians advocating for, we need to pay our staff more, we need to pay our nutritionists more, we need to accommodate part-time, all of these sorts of things, and it just never happened. So more and more work fell on fewer and fewer people. And I think it introduced what I prefer to refer to as moral injury, repeated moral injury, not burnout, because it's not the fault of the individual, it's the fault of the system. But when these individuals, very kind, very hardworking individuals, and not just doctors, but nurses, nutritionists, medical assistants, are forced to continue to self-sacrifice and deliver results that are subpar and aren't to what they imagined themselves doing in healthcare, it reached a boiling point. And as was mentioned earlier, there were unfortunately some legacy contracts that initially had non-compete clauses and pushed some doctors out of the community. And I think that very strongly that we should do away with all of that. That doctors are the ones choosing to go into healthcare. They're sacrificing a decade of their prime years. They're on average coming out with over $250,000 of debt to learn the art and science of medicine. And somehow the people that recruit them, they have the secret recipe, right, so to speak. And I think a lot of physicians, like myself, have recognized that there's alternative ways of providing care that don't cost millions and millions of dollars, that do allow physicians to have complete practice autonomy and work with patients and payers to save the patients money and give them direct access to care.
Dr. Jones, let's give Dr. Kapp a turn now.
Okay.
Well, just to recap quickly, I think, because we've been through this, I think earlier in the conversation, it was a brittle time. It was brittle before COVID. COVID really hurt. It came and burned a lot of people out, and we had the Great Resignation. And there were the business interruptions of being acquired by Optum. I just want to say that here in public and own that transition was difficult. And I think that was, for many, a bridge too far. The other thing I'd say, though, in the same breath, is that the transformation to a value-based organization is hard, and it is not for everyone. And I accept that. I think that, as I said before, having the privilege of hiring 19 new caregivers to date since the time that I've been at Optum has been a real reassurance to me that we are working on the right things, and we are working on the right things in the right way. I mean, that's the proof. That doesn't solve the immediate, I think that the genesis of the question is, it's hard to get care. I can't get access to the care that I had before. It's coming back. We're rebuilding the capacity to provide more care to more people. And it's going to take some time, but we're getting there. But the answer to the question was, why the Great Resignation? And I want to pause and make sure that I answered that question. And if I didn't, please, let's have more feedback on that. Yes, sir. Oh, sure thing. Thank you for that. The question, just repeat the question. The question was, what on earth are you talking about when you say value-based care? Nick had alluded to it earlier in the conversation. The American medical system, has really been for many years a system that pays for volume of care instead of the quality of care. That's outcomes, right? And so what the payer executives in the region, what the legislature is trying to move the care delivery system to, is a world and a future where outcomes drive payment. And that's it requires a complete retooling of how we think about meeting patients and treating patients and families in a community. It's been, I think, alluded to directly and indirectly here, that it requires us reorganizing ourselves about how we deliver care and changing our expectations of what that care is going to be. The transition to value is hard. In most markets around the country, when health systems move, like Optum, from a value, was that a question? No, that wasn't a question. There was a phone. I got it. From a volume-based model to a value-based model, that shift takes about 3 to 4 years because of all the re-engineering that needs to be done inside of the health system and the alignment to the payment model. Did that answer your question? I'm sorry. It's not new. No, value-based care is not new. I would say, though, very directly, that in this market, in the Pacific Northwest, there is not enough value. And that is our future. Building to that is really the challenge. That's why everyone's up here today. That's the future we all believe in and we want to see. We're just trying to move there as fast as we can.
Thank you, Dr. Kapp. Speaker Fahey.
Thank you. So that was a great conversation, and I appreciate it. I would like to say that Representative Nathanson and I, we listen to what's going on in our communities, right? Like, what are the issues that people want us to work on, whether it's better schools or housing, and what happened recently in this community with the hospital leaving downtown and Optum's purchase of OMG coinciding together was that we started receiving a flood of input about access to healthcare. That is why we are here today, and that is why Representative Nathanson and I are here today. And you've got two very policy-oriented, sort of nerdy legislators, sorry, forgive me, nerdy legislators up here at the table who, when that happened and we started to get that input, our brains went to, how do we solve this problem systemically? How can we make sure that we, at the legislature, at the state level, we are doing what we need to do to attract providers to this, to our state and to our community? And then what can we do specifically for our community? So Representative Nathanson went to work on the things she talked about in her opening statement to just how can we respond to what's happening in our community. So I will pass it over to her to talk a little bit about non-compete agreements specifically, because both of us care very deeply about making sure that non-compete agreements aren't driving providers out of our community. But I also want to say that we are legislators, we are policy wonks, but we are also patients, and we are consumers of the healthcare system. And I personally, my husband was dropped from his provider PCB at Oregon Medical Group. I've had to wait weeks for care, follow-up care from an irregular mammogram, physical therapy. My dad had major spinal surgery, and his surgeon left his practice because it was purchased by an outside entity, and had to move many miles away because of a non-compete agreement. So and I have my own horror story about prior authorizations. I don't know if anyone's asked a question about that. Happy to share that anytime anyone wants to hear it. But all of that to say is that this is a very serious issue for our community, and we are trying to, at the legislative level, Representative Nathanson and I, trying to have that responsibility for both how do we fix the system broadly at the state level, and then how can we specifically support our community through this. So I want to pass it to Rep. Nathanson to talk a little bit about non-competes.
Thank you, Madam Speaker. some of you may not be familiar with the contract lingo or the legalese lingo, non-compete. In simple terms, a non-compete agreement means you can't compete with your former employer when you go to work somewhere else. You're not supposed to take business away from them. And by the way, federally, there has been discussion about prohibiting non-compete agreements. In the state of Oregon, we actually prohibit these things. We prohibit non-compete agreements, except it applies to people who earn less than, it's about $186,000 a year. It's supposedly for, you might say, regular jobs, and it's currently not applying to many physicians, many of the physicians that we have. So here's what it means. If a physician has signed a contract that has a non-compete agreement, depending on that particular contract, I'll give you one that's sort of standard. It means that for a 12-month period, you can't have the same kind of job in a similar kind of situation. You know, you're in one doctor's clinic and you go over to another doctor's clinic in a different neighborhood. For 12 months, you can't do that. There's a radius, you know, whether it's 8 miles, 12 miles, 40 miles. What has happened is that because we had doctors in our community who had signed agreements some years ago that Optum had inherited, those doctors then, when they decided to leave practice for one of many reasons, COVID, stress, it was time to retire, or they were uncomfortable with the workplace as the workplace was changing, the requirements on how they delivered and practiced healthcare with their patients. If they were going to leave, it means they couldn't practice, they couldn't see patients for 12 months. Some of them moved out of the area, some moved out of state, some started commuting 45 minutes to an hour every day so that they could work and see patients in another county. I talked to at least a couple of physicians that felt that they couldn't leave, and they were quite worried about that. When the local legislators and I wrote our letter to Optum, and then I talked personally with Dr. Kapp and other Optum representatives. Senator Przanski joined me for the second in-person meeting. Optum agreed not to enforce that non-compete agreement, but they had a further request of us. They said, let's make it a level playing field, please. Anyone who's in this situation, you should prohibit non-compete agreements for everyone, not just us. I agree, that's one of the bills that I'm going to be writing for next year. We will close up that problem and get rid of the non-compete agreements. In 2012, more than 10 years ago, about a quarter of physicians were employed by hospitals or other corporate entities. 1/4. Now it's more than 3/4, 78% are employed by hospitals or other corporate entities. Since 2019, more than 44,000 U.S. medical practices have been purchased by corporations, including health insurers, pharmacy chains, and private equity firms. This is concerning as the business of medicine is starting to influence things. The practice of medicine has always been evolving as science and technology and research bring new capabilities. So the practice of medicine has always been evolving, but now it's the business of medicine that is forcing different kinds of evolution in the delivery of healthcare.
Dr. Kapp and then Ms. DeLisa.
Yeah, thank you. We welcome the conversation about the non-competes. We do need it to be a level playing field for everybody, and so I'm sure that that's the intent that the legislation is drafted around. You know, when I came into the market about, I guess it would have been 6 or 7 months ago, I reminded myself that Optum nationally does not enforce non-competes, particularly for primary care. We do not. enforce non-competes for primary care. And so we appreciated the conversation that accelerated our national policy take hold here, because the truth is, and you laid it out so well, I think that we can't be in a position where we're hurting the community by removing access to this really precious resource that is the caregiver, the physician or the nurse practitioner or the surgeon. That just doesn't make any sense when the common goal is to provide high quality care to everybody that needs it, whether they have insurance or not. It's really, really important. I think that the other thing that's been on my mind a lot is, how can we attract and accrete the talent that we need back to Eugene? That came up earlier in the conversation, and that is certainly as folks who have accountability for running health systems. We have to make sure that we are creating the very best place to work and to receive care. But there's limits to what we can do, and I think there's a broader conversation here with all the stakeholders at the table, and perhaps some that are not, about what's needed to develop the community, the economy, and so on, so that we can accrete and attract the talent that we need to provide care for everybody in Lane County. Maybe not for this forum, but I think it is something that we need to contend with, because as I said before, the being a net importer and the shortage of care is not going away. So we need to be creative about it.
Can I just add really quickly that I think that's great, and I think once again that solution in isolation is going to be doomed, because if we keep on having providers come out with, I think you said $250,000, $400,000 on average now of debt, with this system that they get trained in, it doesn't matter where they go, how much we recruit, they're still going to come out with that debt, and they're still going to be focused on working for a provider who can pay them enough money to pay that loan off. I think that solution, in conjunction with more people getting trained, medication or medical school that is not expensive like that, looking at getting more people in the field, is what we need to do. And also loan repayment, if we have a hard time doing that. We need local, short-term, mid-term, long-term goals when we talk about these solutions. So this may be one part of that, but making sure we get more people into medical school and they're coming out with less debt or other loan repayment programs is also part of that solution. And the other part is, remember, I would just say one thing before I give this up, that if you don't like the system, then please be active in fixing it, because I know we get a lot of claps for my friend here for what he does, and I clap for him and I support him, but we are trying to survive in a system that's broken. So I know people may not have liked that conversation that I gave you about the balancing act, but that's reality. And if you don't like reality, then continue to do what our friends out here in the red t-shirts are doing, and be involved and ask to fix the system, and be then open to being part of those discussions and not divisive in the conversations we have. If we have conversations with everybody in red around the table, we're going to get nowhere. If we have everybody with red and everybody with suits on and everybody in jeans today, then we're going to have a better conversation, because we will have everybody at the table. So if we don't like the system, please get involved and work to fix it. And when we think about solutions, let's think about local, short-term, mid-term, long-term, and also what we can continue to do and work with our legislators at a national level.
Thank you. Okay. So, sorry, I see a hand in the back.
So I'm going to ask you to submit that to the Can Healthcare Forum at Gmail. Yes, we. So that is, yes, that is another question that did come up a lot. So that's a great question. Can we get a medical school here?
So let me backtrack, and then I'll get to that if that's okay. So I do want to reiterate, the system is broken. You feel it on the receiving end. Our physicians work in it. We try to manage in it. I mean, I have been a clinical physician. It's been a little over a decade. And we all know that it's broken. We can do a little bit at the state level. It is ultimately going to get fixed at the federal level. So I want to talk a little bit about practices and them being acquired. There are very few cardiology practices left that are independent, primarily because the reimbursement has changed and they can't make it and support the clinic and support their salaries. I have probably 4 conversations a month at least with groups in town around how can the hospital support them so they can stay independent, or how can we purchase their practice because they're failing, or they're getting ready for retirement and they can't recruit physicians in. So there are certainly entities out there that are gobbling up practice, and there's probably a profit margin driving it. I will say here in Eugene, it is about the survival of our independent practices. It is about maintaining the delivery of surgery, of anesthesia, of any number of different practices that we support through the hospital. So there, it does take all of us. I'm thrilled that Mackenzie's opening an emergency department. It frees up our capital to open an inpatient rehab facility that'll double our beds. It'll bring a traumatic brain injury to Eugene, something that doesn't exist on the Northwest. You have to leave the region to get that. It allows us to work with the county on crisis stabilization and look at what behavioral health needs going forward. We are actually in the process of looking at a primary care residency. If we started the process today, full bore, the first resident would come out 5 years from now. So, but the time to plant the tree is now. So we are looking at a residency program, anesthesia, those types of residency programs, psychiatry, are possibilities, but you have to start with primary care. So a decade from now, it's a long time, but it'll come fast. We may have multiple residency programs in town. Medical school is an incredibly ambitious thing that I don't see Peace Health taking on. But through other coalitions and other leadership in the community, we'd welcome being part of it.
I just think that, Oregon doesn't have one medical school. There are the old schools, but, for 4 million people and growing population, 200 people that graduate every year from medical school is not enough. And Oregon is most likely just going to have medical school somewhere. So maybe on a local level, we need to think about it and actually move forward. So we are actually here and we have medical school here. Because medical school can be transformative for the whole country. In addition that, it will create physicians that will be here. We will be growing physicians here, and then most likely are going to stay here too.
Yeah.
Because in my practice, we literally don't have anybody coming from religious
Right.
every year. We don't know for
Yep.
residency programs.
I hear you. It's
It's big enough, and there is enough
we.
space around the hospital to build research or
Yep.
education.
So, yep, I get it. And a medical school would be fantastic. It is going to take the community across the board, and is something that probably we can look at after we get a residency program up and going. But the other thing to that is physicians are hard to find. We also have to look at CRNAs. We have to look at nurse practitioners. We have to look at our other health clinicians who can, in the right place, expand our access to care and deliver the things that we need to do. If we hold on to a purely MD model, we will not be able to care for the individuals in this room the way that they need to be cared for and deserve to be cared for.
So I see hands from Dr. Kapp and from Dr. Gray, but Ms. DeLisa has been waiting patiently.
What I'm going to do right now is I'm going to talk about the best kept secret in Lane County, which shouldn't be the best kept secret in Lane County, and that's Volunteers in Medicine Clinic. We're a clinic here to where doctors can come in and volunteer their time. That's where some of the doctors that left OMG or Optum came, and they came and volunteered with us, seeing those patients who did not have access to care, who did not have money that could afford to go out and buy their medicines and such, because at Volunteers in Medicine, not only do we see primary care, we have a charitable pharmacy on site. We have the ability to draw the blood, spin it down, and the laboratory runs those tests free of charge for the patients there. It's a community helping the community. So sometimes what I'd like to see us do is maybe just one shift a month, and a shift is 3.5 hours, maybe 4 at the most, per day. And if you would have them come in and volunteer part of their time, then Volunteers in Medicine could open that door and be that bridge or that safety net that could get some of these patients in that can't get in to be seen. So I would just say there are options, but we're better together, and we have to learn how to work together. It's not about the dollars all the time. You know, I look at the bottom line all the time, every day as an administrator, but then I have to take my glasses off and see the person and see the heart of the person that's needing the help. So this is where we have to stop saying, this is how much this is and this is how much that is, but saying, this is what they need.
Ms. DeLisa took us to church. Thank you. Dr. Kapp, and I would love for you, the rest of you panelists, to begin preparing your closing statements. Dr. Kapp?
Yeah, I wanted to go back to the supply part conversation that you were talking about. I think medical school would be amazing. I completely agree, and that is a huge investment that's going to require the buy-in of the entire community and the support in the legislature and so on. I think to your point about other types of healthcare professionals that are extremely powerful, that can deliver care in a different way, we're starting a pharmacy residency next year to increase the number of clinical pharmacists who can help in the community. Amazing professionals who have doctorate level training, who know more about medicines than many physicians, and are a really excellent resource for doing so many things. So we're happy to be able to add that as an investment in the community. And then I was reminded by the comments about student loan repayment. Thank you for bringing that back up. That is a standard benefit package, particularly for our primary care physicians that are joining Optum, and I'm just honored to be able to offer that to all of our new applicants, and trying to explore that for the specialties that require that type of support as well. I think my comments are, the timing is a little off here given where some of the conversation went, but thanks for letting me get back on the mic.
Director Gray, do you have your hand up?
Thank you very much. Just reflecting on all of the comments here, I do think that there are things we can do in the shorter term in order to make the work of healthcare more attractive in our community. I really appreciated your comments, Delisha. It's about doing things dramatically differently. And we have been able to explore that within our federally qualified health center, and it is because we have a very different kind of payment model. So we don't get paid because we code patients the sickest. We don't get paid because we see the most patients in a day. Instead, we get a flat rate, what's called a per member per month payment from our CCOs and also from the state in order to see our Medicaid population, which is the majority of the patients we see. And what we found is that we are able to take this very flexible payment model and provide care in the way that patients need it. So if the patient just needs a phone call because coming into the clinic and for a lot of our patients, that's just not possible because of the difficulty and chaos of the lives that the folks we care for live. And if an email back and forth is what you need in order to answer your question, that's great. Our providers are paid the same, regardless of whether they see someone in person, regardless of whether they take care of them over the phone, over an email, or whether the nurse sees the patient for a follow-up to make sure that that blood pressure medication is working, or whether the pharmacist sees the patient for follow-up. It's all the same. And that transformative type of care has allowed us to do really amazing things. Our providers have 30 minutes with every patient they see. Now, we have really, really complex patients. We are a safety net, and we care for patients who really require a lot. But that 30 minutes, plus our physicians get 90 minutes of administrative time every day where they can respond to messages, they can reach out to patients. And we have seen tremendous recruiting over the last year because we're seeing more and more, not just physicians, but providers of all kinds who are saying, you know, there's a different kind of model that I want to practice in, and a different type of service to my community that I want to provide. And on top of the change that we've made to our care model, when you look at the total cost of care, so what is our patient population costing overall? Even though our model of care is very expensive compared to most primary care models, the total cost of care for our patient population has decreased year over year, a couple of years in a row. And that's unheard of. The cost of healthcare is going up, and yet our patients' total cost of care is going down. And it's because we provide that comprehensive medical home, which our reimbursement model supports. So I think that as we close out here, I want to leave you with some hope that there are things that we can do in the shorter term. There are levers that we can pull. There are things that we can do at the state level and ways that we can transform the model of care that can make things a little bit better. It's not going to make it perfect, but I think we have to continue to focus on what we can do today.
We got through about 8 questions. We got derailed and went down a bunch of rabbit trails. I want you guys to all show me your surprised faces. So we've reached the end of the time for questions and answers. So I would like you guys to deliver your closing comments and action statements, and again, try to keep it under 2 minutes. After that, we'll have Councillor Groves come up and speak to us as well, and then we'll close out. So I'm going to start in the opposite direction this time, and we're going to start with Ms. DeLisa and end with Speaker Fahey.
Okay. What I will say, this has been a good start to a conversation. Instead of us trying to boil the ocean, I asked and employ that we try to do what we can do now to help the situation. It might not cure the whole issue, but it's a start. And the best thing about it, if you take one step, then it'll take the second step, will be a whole lot easier. So let's get going.
Before I get to the call to action, I'd again like to thank everybody for coming and participating with this conversation. I think the diversity of opinions and ideas is fantastic. Just briefly, as far as value and outcomes for care, value-based care, I think there's a lot to be said for a model that values time, right? And I think that the per member per month model is exactly how my clinic operates, and I think is a way of isolating doctors from a lot of the complexity and conflicts of interest and problems that we have. And when we have a healthcare system in the Pacific Northwest that isn't bought in fully to value-based care, we have an opportunity to skip the reality of, you know, it takes money to make money, and it takes huge investments to build these systems to optimize value-based care models. And if we can instead devise a way to care for the entire community in a easier to manage and administrate model, like a per member per month model, we can experience all of those wonderful benefits that you mentioned. And my call to action is, you know, not just to talk, but to vote and to get engaged this next legislative session, right? There's hundreds of bills that come forward every year on healthcare. Not all of them make it to a vote, but there's going to be a key few that address things like universal access to healthcare, things like the corporate practice of medicine and non-competes and all of those sorts of things. And as the legislative session progresses, we can all take it a step further and let our representatives know what we support, why we support it, and share our experiences. Thanks again.
Thank you both. I think where I will leave you is just making sure that I'm sharing what we are doing as a county in order to focus on improved access to health care. So I mentioned the growth and expansion that we have within primary care by opening 2 new clinics. We also are opening our first full-service dental clinic that will be in Cottage Grove. So we are working on recruiting for our dental director to get into that space, because it's not just physical health care that we don't have enough of. Particularly if you have Medicaid and you need to see a dentist, it's really, really hard. So we have to think about all of the different types of care, behavioral health as well. We're doing tremendous work at the state level to talk about recruiting additional providers, how to incentivize individuals to go into safety net clinics, which is harder work, and it also can have a lot of rewards, but it's harder work than providing telehealth therapy, which is what a lot of folks leave our practices in order to go do because of the intensity of that workload. So what we're looking at is the models that we have in primary care of team-based medicine, talking with our CCOs. Trillium's a great innovative partner with us in this as well, to think about how do we transform behavioral health in a similar way, to have team-based care and to focus less on how many people can I get through the door, because that burns out providers. So that's our vision and future for outpatient behavioral health. And then, of course, Dr. McGovern mentioned Crisis and Stabilization Center, which we are working very, very hard on getting construction started here within a year to a year and a half. So there are big lifts ahead of us, but that will serve as essentially, it will not be licensed as an emergency room. It will care for people of every level of psychiatric emergency. So operate very similarly to a psychiatric emergency room as well as urgent care. Another desperate need for our community. So as just thinking about where we're headed and our strategy, we are focused on bringing access to healthcare, particularly in the areas where we know that we need to step in, because often the private sector can't afford to step in where we are stepping in. So we're working on that as the county and look forward to communicating with all of you along the pathway.
I think we would be remiss if we didn't all leave with a feeling that we left out a part of our conversation tonight. And two parts. When you had said, sometimes you just have to stop all this talk and think about the patient or the person in front of you, we have a significant equity issue in our area and our country. And we continue to have structural racism, and levels of poverty. We have more people over 55 becoming homeless in this county than anywhere. It's huge. So while we talk about these, and this forum is great for this, we have to remember and continue to refocus on, it's tough for you, and it's really tough also for our communities that have been traditionally and continue to be marginalized to this side of our communities. And this may have not been as much of the forum. We focused a lot on the nuts and bolts, but that is the outcome part we all can focus on. And my friend in Demond and I are working endlessly and tirelessly and need your help to continue with that focus. We'll continue to have these conversations as well, the short, midterm, and long-term goals. And we want to continue to have the focus on our communities and how we can help them and the best way to do that. And we would love your input. We have clinical advisory panels, which are often provider administrators. And if you're a provider out there, would love you to join that. We have our community advisory councils, where we have members who receive Medicaid and actually at-large members as well, who come and tell us what they like and they don't like and what needs to be fixed. So I think it's amazing that you're here because you've already shown that you want to be involved. There are other avenues and ways to do that as well, specifically in that healthcare area. So Community Advisory Council, Trillium has one, Pacific Source also has one. Please be involved that way. Let us know what you want us to focus on in all of those issues. Lastly, I really do want to just reinforce what you said about voting. Please vote. Please encourage your kids who are turning 18 to vote, everybody around you to vote. I know sometimes it feels like it may not matter because you're in a certain place and there's certain, but it does. It matters. And you're an example to everybody around you. Thank you so much.
Well, I want to say thank you. And I learned a lot listening, and I appreciate the honor of being here. It's wonderful. I'll be brief. I don't want to retread some of the things I said before. We are here for the long haul. We are here to reimagine and re-engineer healthcare delivery in Eugene and beyond. And those of you don't know me, and you don't have to believe me, the proof, the work of our hands will be the proof, and it will come. I would say that the future is not clear. I don't have all the answers. We're going to make mistakes. The experiment of having physician-directed healthcare in this country, over 50 or 70 years didn't work. It didn't work. So we have to try a new way. And that is the work that I signed up with and that my new team that is forming for Optum Oregon is here to do. I do believe that we can get to a sustainable, high-quality, equitable care delivery system. And I'm really looking forward to partnering with everybody at this table and other partners who are not to deliver that to the citizens of Eugene.
I may go a little bit over 2 minutes. So I just, again, want to acknowledge that we all kind of live, function, get care in a broken system. I grew up as a hospitalist. Delivering care in the hospital, in the clinics, anywhere is a team sport. And so at Peace Health, we work with everybody at this table and a few in the audience as well. We collaborated through the pandemic. We collaborate every day on how we improve care delivery in the communities. So Peace Health has been here for a very long time. Before I got here, we'll be here for hopefully a very long time after I get here. We did close University District Hospital. We've talked about that a little bit. It was about a $24 million loss annually. And we only have so much money to invest. So what we save from University District goes back into the community. We're breaking ground on the inpatient rehab facility next month. If you have a stroke, if you have a car accident, you have a traumatic brain injury, we've increased the capacity to have your care delivered locally. We were able to partner with the county on the Crisis Stabilization Center. We're able to look forward to more investments in behavioral health, which this community desperately needs. We are opening 70 more beds at Riverbend in the next 2 years, a couple more ORs, so we are expanding access in the hospital. I will say as a hospitalist and a hospital administrator, I do not want to see you at Riverbend. That's not where you belong. If you can get your care in the community and we can keep you healthy and out of the hospital, I am all for that. So the other thing, there was a comment made about being in backwoods healthcare, which I took a little bit personally. So I just want to talk a little bit about what Riverbend delivers. The University District wasn't Eugene's hospital, it was the community's hospital. Riverbend is not Springfield's hospital, it is the hospital of the broader community. We have the only comprehensive stroke center north of Sacramento and south of Portland. Do you have a stroke, there's a pretty good chance we can pull that clot out or dissolve it. We are doing minimally invasive cardiac surgery, so the old way where we open up the sternum and you're in the hospital for 5 or 6 days with significant pain. We now go through or have the ability to go through an inch or two on the side. You're in the hospital for 3 days, much less discomfort. We're doing robotic valve replacements. We were the first in the state to get the most advanced robot. That's number 4, we're looking at number 5. So we have work to do, we have opportunities. I'm looking at a couple of our ER docs over there who remind me daily about our waits in the emergency department lobby, something we are working hard to decrease. So we are not perfect. There's plenty of gaps that we have, but we do deliver high quality and high-end healthcare to the communities that we serve. And we intend to continue to do that for the next 7 decades. So I appreciate being here tonight and with all my friends. So with that, I'll end. Thank you.
So I think I'm the one that had the bit on the news about the backwoods healthcare. And the context of that is, I'm sure you're very well aware, clips get taken out of context. The context of that was the access to healthcare, not the quality of healthcare. So I just want to make that very clear. Representative Nathanson.
Thank you. I want to begin with a couple of thanks. I want to thank Dr. Kapp for working with us. I want to thank Peace Health for working with us as we tried to find solutions and look to the future. I want to give a special, very important thanks to Eve Gray, because Eve Gray led a lightning speed process. I've never seen bureaucracy move so fast. This fall, what you're going to see, remember the legislature just passed money for an innovation fund in February. It's already going to be put in place. This fall, you're going to see a new Eugene and Peace Health EMT responder, Whitebird Mobile Crisis Service expanded, street medicine, telehealth, and expanded urgent care hours. I'm already drafting bills for the legislature to consider in 2025 based on discussions over the past 12 months with people involved in healthcare and emergency response. It includes doctors, hospital staff, public health officials, higher ed, and emergency responders. Here's a preview of just 3 of those bills. In broad terms, I'm tackling corporate practice of medicine, access to health care and urgent care, and access to affordable prescription medications at local pharmacies. 1, there will be a bill to prohibit non-compete agreements and contracts for staff physicians. 2, working with local advisors and Lane Community College, OHSU, Bushnell University, and others, I'm preparing a bill to loosen the student-faculty ratio for nursing students. By the way, I'm also working with the Oregon Oregon Nursing Board on this. The idea is to graduate more nurses and get more working in Oregon. The limit right now is no more than 8 nurses in a class. We believe we can safely increase that by 1 or 2 for every class, every term, every school, and get more nurses to work in Oregon. Number 3, define urgent care clinics and require registration so that we can have a basic standard of care that you can depend on if you show up at an urgent care clinic. Hospitals are highly regulated. Doctors are licensed. Nurses are licensed. Plumbers, truck drivers, people who do a manicure. But urgent care clinics? Nothing. Most of these experiences at urgent care clinics are fine, but not all clinics operate alike. Some have doctors, some don't. Some have x-ray, some don't. Only one will see someone whose insurance is from Medicaid, and that's thanks to Peace Health. Finally, I am working with congressional offices to find ways for state and federal collaboration to crack down on anti-competitive business practices, keep community pharmacies open, ensure prescription drugs are accessible and affordable locally, and put patient care before profits.
Thank you, Representative Nathanson. Those of you in North Eugene have a fabulous representative, so. I already talked a little bit about what a difficult time it is for patients in our community, and I also really want to acknowledge, I see some providers in the audience, and I really want to acknowledge that it is a difficult time for providers as well. You are doing tremendous work in a tremendously broken system, so thank you for that. So the call to action part of our closing statements, Representative Nathanson and I, the legislature goes back into session in January of 2025. So we are both hard at work about what are the healthcare related topics that we're going to take up in the legislature next year. So I want to pull, Nathanson went into some specifics. I want to pull back a minute and just talk at a high level about some of the issues that we'll take on. So the first one is supporting the Oregon Health Plan. 1 in 4 Oregonians get their health care through the Oregon Health Plan. So it's very important that we support that program and that we make sure it's successful. We need to renew, the legislature needs to renew its funding source next year, so we will take that on. There will be a renewal of the contracts with the coordinated care organizations. What do we expect of them? Payment rates, that sort of thing. So supporting the Oregon Health Plan is really important. The Oregon Health Plan is also doing some really interesting work that I don't have time to go into detail about social determinants of health. So using Medicaid to pay for things like housing for folks who need that to get well. It's really interesting, creative stuff that we are doing here in Oregon. We are also going to continue the work on workforce. We've made some big investments in recent years on that. There's more to do. I think that Rep. Nathanson's comment about nurse staffing ratio or training ratios is part of that. And then pharmaceutical prices, drug prices. We have done some interesting things at the state level in recent years. We've capped the price of insulin at $35. We've tackled the regulation of pharmacy benefit managers. There's still more to do on that front. Pharmacy benefit managers are the middlemen of the pharmaceutical industry that drive up prices. So we'll be taking that issue on again next year. And then finally, there's a program that many low-income Oregonians get pharmaceuticals through called the 340B program. It's a federal program, and we will be taking on legislation to try and protect that program next year. The final thing I want to talk about is a bill that we considered in the short session this year on what's called the corporate practice of medicine. So Oregon has long had a prohibition on the corporate practice of medicine. Basically, clinics need to be majority owned by providers. That's because of weighing ethical concerns about patient care versus financial considerations. But there are a lot of loopholes to that law right now. And so we considered a bill in the short session in February that would have closed some of those loopholes and really ensured that that healthcare is provided by entities that are majority owned by providers. That bill passed through the House. Representative Nathanson and I both voted yes for it, but it died in the Senate. Our friends at Optum did not really like that bill because they would have had to undergo some pretty significant restructuring to comply with the requirements, nor did any of the other many corporate lobbyists that showed up at the Capitol to lobby against it. That bill is going to be brought back next year. And I hope to see it pass. I do feel like we need to address the root causes of why we are seeing independent physician practices being bought up by outside entities. And we are doing that. And we also need to make sure that it is physicians that are owning the practices that are providing care here in this state. So we'll take that bill up again. Big thanks to, he's not from this community, but Representative Ben Bowman up in the Tigard area has been championing that bill and working on it in the interim. So the call to action part is we're going into session. Representative Nathanson and I, you should email us. Call us, tell us what you're thinking about healthcare. This, the session starts in January, but now is the time to engage. If there's things that you want us to put forward, we are working on those things right now. So please do get in touch with us. We both read our emails. We will both respond to your emails. And so the input from the community about what's going on in this healthcare space is really, really important to us. So please do reach out. And when the session starts, submit testimony, come up to Salem, or do it virtually. You can testify virtually as well if you have opinions about any of these bills or if they are impacting your life in the way that you receive care.
Before we close out, Councilor Randy Groves has some things to say, and I cannot tell you enough how much Councilor Groves has supported this whole venture ever since it started out kind of as a harebrained idea to become this evening.
Thank you, Jensina. Delisa Mission-Tubby said something that I want to emphasize. This is just a first step. If you look at or ever read the saying by philosopher Lao Tzu, a journey of 1,000 miles begins with a single step. That's kind of what this is. But I want to thank our panel. Thank you for being here, and I want to include in that David Butler from McKinsey Willamette, who gave us some really good news tonight. I want to thank the church and Pastor Van Clements and the congregation for opening up this beautiful facility for us to use. I want to thank all of you for taking the time out of your evening to be here for this important discussion. I'm sorry we only got through 8 questions of well over 60, but it's a complex issue that really deserves more discussion. And I really want to end by thanking the Churchill Area Neighborhood Association Board of Directors who put this whole thing on. And there's a lot of work that went behind the scenes. It just didn't materialize like this. We've been working on this for months. I especially want to thank Jensina, our talented moderator, but also she was a workhorse behind the scenes. As was our CAN board chair, Sarah Zoll. Thank you, Sarah. And the last point I want to make before I hand the mic back is how important it is to be involved. And one way to do that is through your neighborhood association. I'm not aware of another event that's occurred like this that was organized, run, fundraised, the whole process from soup to nuts to bring this important dialogue out into the community, and not just for the Churchill area neighbors, for our entire city. I mean, we have neighborhood leaders from other associations. I know we have Lynn Woodrich and Ty Bruce Zimmerman, who are co-chairs from Active Bethel Community, who also donated to put this on. So it's been a big effort, but I'm hoping we have more of these. And I appreciate the bravery and the work of stepping out. And I know you guys have been just really nervous about this, but I think you knocked it out of the park. Thank you all again for being here.
Thank you, Counselor. Again, all of your questions and as many of the panelists' responses as we can get. So you guys have been provided a list. I will send more to you. Will be posted at eugenecan.org. There is a button to click to go to the Citywide Healthcare Forum. I would love to see the panelists looking at more of the questions and seeing how many more responses we can get, because we do have about 62, actually probably about 75 more that came in this evening. Yes. So, Randy did my shout outs for me. Please, if you brought in a beverage container or a water bottle or something, please gather it up and prepare to take it out with you so we can leave the auditorium as we found it. And the staff and especially the volunteers at Willamette Christian Center who are operating the sound, who have been working security, who have been making sure the doors are locked that need to be locked and the ones unlocked that need to be unlocked, has been fantastic. And our panelists have been very transparent, very open. I've been actually pleasantly surprised. My expectations were lower. So thank you for coming, and be well.